would like to welcome our guest expert today, Dr. Mike Zabel. Dr. Zabel attended Lamoni College in, Graceland University in Lamoni, Iowa. Maybe he can tell you a little bit about the other celebrities that went there. Went to med school at Washington U in St. Louis, and then did 2 years of training at Duke. And we will just, we're okay with that completely. And we're sure you got a great education at Duke, because he did come to Lawrence 2 years later and has been here since 1995, practicing cardiology. And so we welcome him. We thank him so much for putting this presentation together just for us today. And with that, I will let you take it away, Dr. Zabel.
Thank you, Kathy. I appreciate that warm introduction. Even though, yes, I did spend some time at Duke, but let me just make it clear. I was born right here in Lawrence. Actually, I was born, I'm sitting in my office on the LMH campus. And actually, I was born, as best as I can tell, about 50 feet in that direction from where I'm sitting right now. So I was transplanted to Durham, North Carolina for a few years. I was actually there during the Christian Laettner and Bobby Hurley years where they won back-to-back. And they are my second favorite basketball team still, but it's a pretty distant second. So I can hold my head up high and claim the Jayhawks. And for those of you that were wondering about the reference to Graceland College / university, it was college when I was there, university now. That would be the most famous person to graduate from Graceland would be Bruce Jenner, who's now Caitlyn Jenner. And Bruce at the time was, he trained at, he was a student at Graceland and trained at Graceland for the decathlon that he won in the Olympics. So that's Graceland's claim to fame from a few decades ago. I want to share my screen here. All right. Does that look okay?
Yes.
Kathy, does that look okay?
Yes, it does.
Okay, great. So the topic that I'm going to address today is cardiovascular disease in the elderly. And I put this together this week. So this is up to the minute new stuff, although quite honestly, a lot of what we're talking about today has been around for a long time and is pretty tried and true cardiovascular advice. When you approach a topic like this, I think the first thing that you have to address is, well, who exactly are the elderly? So this is my nephew, my son's youngest child, my youngest brother's youngest child, and this was about a year ago. So, when we talk about the elderly in medicine, there are frankly a lot of different definitions. So I would say many doctors are probably like many in social situations too, the elderly is anybody who's at least 10 years older than you are, right? So that's one definition that you can use. In medicine, we like to be a little bit more precise than that. Generally, in medical literature, if you start reading about studies in the elderly, generally that's referring to individuals over the age of 70. So sometimes it's 65, sometimes it's 75. The most common definition would be over the age of 70. You'll also hear a lot of other terms thrown around. One of the ones that I use in the discussion today is octogenarian. Obviously, that's anyone over the age of 80. Nonagenarian would be anybody over the age of 90. Decagenarian, anybody over the age of 100. And you get the picture. But for the purposes of our discussion here this afternoon, when I use the term elderly or advanced age, I'm generally talking about individuals over the age of 70. So, why is this an important topic? Well, the fact of the matter is, like with a lot of things with the human body, as we get older, we are more likely to have heart problems. Just like as you get older, you're more likely to have arthritis and you're more likely to have other things. You're more likely to have heart disease as you get older, even if you take great care of yourself. I mean, that's just a fact of life. So if you do coronary arteriograms on people, that's heart catheterization, we see that the older you are, the worse disease you tend to have. And there are obviously many exceptions to that rule, but it's a pretty good rule. If you look at autopsy studies, even in people that don't have clinically manifested heart disease while they're alive, 50% of women over the age of 70 and 75% of men over the age of 70 have significant obstructive coronary disease. So CAD, when you see that in my slides today, that acronym stands for coronary artery disease. So that means cholesterol blockage or partial blockage in the heart arteries, the coronary arteries. Another fact, octogenarians, so those over the age of 80, about 1 in 20 of the US population, but about 1 in 5 of all hospitalizations for heart attack. So, this is why it's an important topic, because elderly people are more likely to have heart disease. The other thing about cardiac disease in older patients is they are less likely to have typical symptoms. So typical angina is chest pressure or dull ache or pain with activity that gets better with rest. Sometimes it radiates to the neck or the shoulders. That's termed typical angina. That is not all that common in elderly patients and older patients with heart disease. They are much more likely to have what we call atypical symptoms. So shortness of breath, nausea and vomiting, syncope, which is the medical term for fainting or losing consciousness. Elderly patients are also more likely to have what we term secondary heart attacks. So myocardial infarction is the medical term for heart attack. So when you see MI, that means heart attack. So secondary myocardial infarction basically means a heart attack that doesn't come primarily from an acutely occluded heart artery. That's a primary heart attack. That's the most common kind of heart attack. Secondary heart attacks occur from increased stress on the heart, from pneumonia or other infection, from a fractured hip, from surgery, those kinds of things. So secondary heart attacks are much more common in older patients than they are in younger patients. And when we talk about the symptoms not always being typical, it's very important that you, if you have these symptoms, or if someone close to you had these symptoms, that you can recognize those. Because treatment of unstable angina, which is the step right before you get to a heart attack, can prevent a heart attack. Treatment of a heart attack at early stages can prevent the complications from a heart attack, like heart failure and major arrhythmias and that type of thing. So as we get older, it's harder and harder to identify the symptoms from a heart attack, but it's more and more important. Why are heart attacks more common, and why do they tend to be worse in elderly patients? Well, a lot of reasons. So for one reason, elderly patients are more likely to be dealing with other health problems. So more likely to have kidney abnormalities, more likely to have had a stroke, more likely to have diabetes. And all of those things increase the risk of an adverse outcome if you have a bad heart event. When we talk about cardiac events, we're mostly talking about heart attack, but we're also talking about acute arrhythmia or acute heart failure. Some people lump strokes into that. Stroke is not a cardiac event, but it's a vascular event. So when we talk about cardiovascular events, stroke is part of that. We've already talked about that elderly patients are more likely to have extensive disease. But the other thing, and this even a lot of physicians find this surprising, but the statistics are compelling, and it's real. Older patients are less likely to get beneficial therapy than younger patients are. And sometimes the reasons for that are clear. For example, when we talk about thrombolysis, okay, that's clot dissolving medication. So if you look at patients presenting with heart attacks, many fewer older patients get thrombolytic drugs than younger patients. Now, there's a good explanation for that, at least to some degree, because older patients are much less likely to be good candidates for thrombolytic drugs. They're more likely to have contraindications like previous stroke. But even if you look at other things, so PTCA is angioplasty, much less common. So this is older patients. These are younger patients. CABG is coronary artery bypass grafting. So that's bypass surgery, half as frequent in older patients as younger patients. And again, some of that is explainable. Older patients may have many contraindications to having bypass surgery, or frankly, they may just not want it compared with younger patients. But even if you look at pretty simple things, okay, so we've known for 32 years now that giving aspirin in patients of the throes of a myocardial infarction, a heart attack, decreases the risk of dying from that heart attack. And yet, if you look at the statistics, fewer patients that are over the age of 75 get aspirin when they present with a heart attack compared with patients under the age of 75. And it's really not enough that difference is too much to be accounted for only by contraindications to aspirin. So, to some degree, this is an indictment of my profession, cardiologists and maybe physicians in general, that we don't tend to treat elderly patients as aggressively as younger patients, even when there's probably no good reason not to do that. So that's kind of the bad news about this. Now, the good news about this is that intervention for heart disease in the elderly is largely very effective. So medical treatment is very effective. We're going to talk about some of those things, some of the medical treatments for heart disease. Stenting, outcomes for stenting, so putting mesh tubes basically into occluded or partially occluded arteries, works very well in older patients. Outcomes are similar to younger patients. Now, there are increased risk of certain complications, including stroke and vascular complications like bleeding. But those differences are fairly small. And the fact of the matter is that stenting, particularly for acute coronary syndromes like heart attack, works very, very well. Even aggressive treatment like bypass surgery, so CABG is coronary artery bypass grafting, as I mentioned, survival is better in older patients who are treated with bypass surgery. And although the mortality rate, approaches 5% in individuals over the age of 80, and that's not trivial, it's not huge. In fact, I think a lot of people would be surprised that you can take, an 85-year-old who's in reasonably good health and do multivessel bypass surgery and have a 95% chance of surviving that. The hospital, of course, may be complicated. It may be prolonged. If you look at individuals under the age of 60 who have bypass surgery, the average length of stay is a little under 4 days in the hospital. If you look at individuals over the age of 80 who have bypass surgery, the average length of stay is about 7 days. So it's about twice as long. So, it's not a walk in the park for some of these procedures, but they can and do work very well, even in octogenarians. I really want to spend a significant amount of time here, though, talking about prevention of heart disease, because just like with so many things with our health, when you're talking about heart disease, prevention is far better than treatment. If we can address your risk factors for heart disease and prevent a heart attack a year or a decade from now, that's a whole lot better than dealing with it when it happens. So, the traditional risk factors for heart disease, these haven't changed in 40 years. So it's tobacco use, it's high blood pressure, it's high cholesterol, it's diabetes. And all of these are modifiable risk factors. There are other risk factors for heart disease that are not. So we've already talked about one of those, right? Getting older. So having more birthdays puts you at higher risk of heart disease. you can't stop that from happening. Well, there's one way to stop that from happening. You can die, but I don't recommend that as a prophylactic treatment for preventing heart disease. So, you can't do anything about the fact that you accumulate a birthday every year, and that does put you at higher risk. If you're a man, you can't do anything about the fact that that puts you at higher risk. If there's a significant family history, you can't do anything about your genes, at least not in 2022. You can't. Maybe at some point you'll be able to. But these things you can definitely address. So I'm only going to spend a little bit of time on smoking, because my bet is, however many of you are on this Zoom presentation, if there are any smokers, you probably know this already. Smoking does a lot of bad things, and none of them are good for the heart. So smoking increases blood pressure and heart rate and vascular resistance and catecholamines. Those are stress hormones. And they increase risk of blood clotting, and they decrease good cholesterol, and all of that is bad. Okay, it's bad in the short term, it's bad in the long term. The good news, though, is that, and a lot of people don't realize this, that smoking cessation is very effective at reducing cardiovascular risk within a pretty small amount of time. I have patients every week that tell me, Doc, I'm 82. I've been smoking since I was in junior high. What good is it going to do me to stop now? Well, the fact of the matter is, it's going to do you a lot of potential good. So smoking decreases the risk of mortality by 25 to 50%. The risk of a heart attack is cut within days of stopping smoking, literally within days. The risk of a stroke, a little bit longer, but still decreases within a few weeks. Now, there are some things about smoking that don't decrease quickly at all. The risk of cancer, for example, goes on for years and even decades. But in terms of cardiovascular health, patients that smoke can greatly decrease their risk within a fairly short period of time. The one thing I'll say about interventions, so family support is important. Nicotine replacement is safe, even in older patients, and it's effective for many people, though not for all. LMH has a smoking cessation clinic, and Allison can probably address better than I can how to access that. But LMH does have a clinic that can help if you are a smoker, or you have family members or loved ones that are smokers that want some help in quitting. High blood pressure, very common in this age group. Hypertension or high blood pressure is one of those things that if we live long enough, probably all of us will get it. And that's not quite statistically true, but it's close. So, 60% of adults over the age of 60 have hypertension. There's an 80% lifetime risk of developing hypertension. The most common kind of hypertension in the elderly is what's called isolated systolic hypertension. So systolic blood pressure is that first number you get when you get your blood pressure numbers, right? It's like 120/70. Well, 120 is the systolic number. That's the blood pressure in your arteries when the heart is squeezing, when it's contracting. Systolic hypertension with normal diastolic, that's the second number, the lower number, is very common after the age of 70. In fact, 3/4 of all individuals with high blood pressure after the age of 70 have that type. It's still dangerous. Okay, it's not quite as bad as if you have both the systolic and the diastolic pressure elevated, but it's still dangerous. So even isolated systolic hypertension greatly increases the risk of heart attack and kidney dysfunction and stroke. How high is too high? Well, if you're under 80, the current guidelines, and this changes from year to year, but the current guidelines in 2021 going into 2022 are to initiate medical therapy if the systolic pressure is greater than 140 or the diastolic is greater than 90, either one. If you're over 80, the recommendation is to tolerate a systolic blood pressure a little bit higher. So some, like the American Heart Association, say 150. Some, like the American College of Physicians, say 160, but somewhere in that range. So if your diastolic pressure is normal and you have isolated systolic hypertension, we generally tolerate a little bit higher blood pressure before we treat. One problem with treating high blood pressure in this age group is that you tend to be more sensitive to drops in blood pressure when you stand up. So we've all had that feeling, right? You stand up after you've been sitting down for a while and you get kind of woozy. Everybody has that. It's very common. It's virtually universal. And it's not dangerous unless it gets to the point where it makes you fall. Then it's dangerous. And older people are more likely to have that to the degree that it makes them fall or nearly fall. So that is something that we have to be careful for when we're treating high blood pressure. And it's worse with some kinds of blood pressure medications than with others. You hear a lot about salt restriction in treating high blood pressure, and I'm not here to entirely poo-poo this, but it probably gets a little bit more airtime than it deserves. So there's not a lot of bang for the buck when it comes to lowering blood pressure with salt restriction. Now, if you have heart failure, absolutely, very important. But if all you're treating is high blood pressure, you want to be careful with your salt intake, but weight loss is significantly more effective than salt restriction. So in some people, losing 10 or 12 pounds of weight can lower their systolic blood pressure by 5 to 10 points. That's a lot. If you restrict your sodium intake to under 2 grams a day, which is what the American Heart Association recommends, from the average American gets about 4 to 4.5 grams a day, you see about a 2 to 3 point drop in systolic blood pressure. So, and that is significant, but again, not a lot of bang for the buck. One thing that gets you a lot of bang for the buck is medical treatment. I'm not paid by the drug companies. I'm not here to push medications on people that don't need medications. But if you need medical treatment to control high blood pressure, the good news is it works really well. So we have, and it works really well in the elderly age group as well. So we have a lot of data for that. The SHEP trial, which came out a couple of years ago, stands for Systolic Hypertension in the Elderly Program, and showed that stroke risk when you treat high blood pressure in this age group, so over the age of 75, stroke risk is decreased by 30%, heart attack risk is decreased by 25%. There's a lower risk of kidney failure, including the need to go on dialysis. There's a lower risk of heart failure, lots of benefits from hypertension treatment. The HIVET trial, all of these patients were over the age of 80, almost 4,000 patients enrolled, treated with a thiazide diuretic. And dapamide, we don't use that much in this country. This was primarily a European trial, but it'd be very similar to hydrochlorothiazide or chlorthalidone. Those are also thiazide diuretics that we use a lot more of here. Perindopril is an ACE inhibitor. We also don't use a lot more here, but we have lots of ACE inhibitors like lisinopril and Prenavil and Ramipril, and some of those would be familiar to some in the audience, I'm sure. But this study, again, all patients over the age of 80, the risk of fatal stroke over 5 years was cut by over a third. The risk of death from any cause was cut by about a quarter. And that's pretty impressive because, a lot of people in this age group succumb to things that have nothing to do with their blood pressure, right? Cancer, for example, has nothing to do with your blood pressure. And there'd be no reason to think that treatment of blood pressure would decrease your risk of dying from cancer. But it does decrease your risk of dying from a stroke and dying from heart attack and dying from kidney failure and dying from heart failure. And so all-cause mortality is decreased when you treat. I'm not going to spend time, but I'm happy to answer questions about the specific medications. Suffice it to say, there's a lot of them. We have more medications than we've ever had to treat high blood pressure. And the good news for that, it can be confusing, but the good news for that is that we can almost always find medication that people don't have side effects on. There's really no reason to expect that you'll have significant side effects when you're getting treated for high blood pressure in 2022. We just have so many options that are available. These are some of the major classes that are available and that we use on a pretty regular basis. One thing that I think is important to understand is, if your doctor, whether that's a primary care doctor, a cardiologist, a nephrologist, whoever's managing, if you have hypertension, whoever's managing that problem, recommends that you be on multiple medications, that doesn't necessarily mean that you have the worst high blood pressure in the world. Okay. We use combination therapy more and more frequently now, even for people with modest high blood pressure. There are some people that just need one medication. But the majority of people that need medical therapy for high blood pressure do better if they're on 2 or more at lower doses. So the key here is you use 2 or more medications at low doses rather than one medication at higher doses. So the efficacy tends to be better. There's a greater response rate. There tends to be fewer side effects. Both those you can feel and those that are picked up in labs, like effects on the kidneys or effects on your lipid profile. And although it's counterintuitive, sometimes, frequently even, 2 drugs at a low dose would be less expensive than 1 drug at a higher dose. So more effective, less likely side effects, and even less expensive in many cases. So let's turn our attention to high cholesterol. After high blood pressure, high cholesterol is the most common modifiable risk factor for cardiovascular disease in the elderly. It's true that just like blood pressure, cholesterol levels tend to increase with age, and that's primarily an increase in the LDL cholesterol, and that's not good, because the LDL cholesterol, as probably all of you know, is the bad cholesterol. So we have LDL and HDL. There are a few other kind of permutations of those, like VLDL and whatnot. They're not as important for this discussion, but LDL is bad cholesterol, HDL is good cholesterol. So you want to keep your L low and your H high. Well, with age, our LDL cholesterol tends to climb, and that increases cardiac risk. Good news again here is that medications, diet is effective in some people and to some degree. Medications are very effective, and we have now had effective. So when I first started practicing cardiology in 1995, the first statin just came out. That was Mevacor, which is lovastatin. It's still available. That came out in the mid-90s. And the statins have revolutionized the treatment of heart disease in general, but high cholesterol levels in particular. They are no longer the only game in town. They were, for about 25 years, really the only drug that had been shown to decrease cholesterol levels and decrease risk for heart disease. That's no longer the case. There are now some non-statin medications, which is good news because not everybody can tolerate a statin. But there are now some non-statin lipid-lowering medications that can be used that also have been shown to have beneficial effects on cardiovascular outcomes. But we tend to focus on the statins because they're cheap. They work quite well. They're given once a day. They're oral. Some of the newer ones have to be injected like insulin does, so that's not as attractive. One of the first trials to look at statin therapy in elderly patients was the 4S trial, which was a simvastatin trial. It had over 4,000 patients overall. About 1,000 of them were over the age of 65. And there was about a third decrease in heart attack and stroke and all-cause mortality. The CARE trial was one that was published just a few years ago. The 4S trial is 15 years ago. The CARE trial is just a few years old now. Showed basically the same thing in patients over the age of 65. The lipid trial was also 2 or 3 years ago, looked at patients over the age of 75 and showed that treatment with pravastatin, which is one of the available statins, decreased stroke and heart attack. Here again, there are some misconceptions out there about statins. Can they cause side effects? Absolutely, they can. Any medication can. Muscle aching is the most common. That tends to go away in most people, even if you continue to take the medication. But there are some people where it doesn't, and it has to be stopped or switched to a different statin. One common misconception, similar to stopping smoking, is that it takes years for the benefit to come, to come on. And you can see why people would think that, right? I mean, you could say, well, look, I'm 80. I just had my first heart attack. It took me 80 years to develop this cholesterol buildup in my arteries cause a heart attack. It'll take me 80 years to get rid of it. Well, that's not really true, actually. We know that with statin therapy, it doesn't take years. It takes weeks to show benefit. The risk of heart attack in an acute setting goes down within about 2 weeks. And after about 6 months of therapy, you can show significant improvement in stroke risk and heart attack and heart failure risk. People worry that they're more likely to have side effects if they're older. With statins, at least, that does not appear to be the case. If anything, there tends to be a little bit less side effects in the elderly than in younger people. And cost is also, for most of these, is not an issue. Most of the statins available in the United States now are generic and are available at a $3 to $5 a month cost. Aspirin's been in the news a lot lately, right? Because we being the medical profession, has kind of changed our mind about routine use of aspirin a little bit. You see a lot of kind of confusing stuff. I've tried to boil it down in this slide to the simplest. And the best advice I can give you is to check with your primary care provider or cardiologist, if you have one, and ask them if you should be on aspirin. But as a rule of thumb, which is a pretty good rule of thumb, you should be on aspirin if you have vascular disease. So if you have a history of bypass or a stent or angioplasty or stroke or previous heart attack or claudication, which is not enough blood flow to your leg muscles, any of those things, you probably should be on at least a low dose of aspirin, unless there's a strong contraindication to that, which some people do have. If you don't have those things, you probably should not be on aspirin. It used to be that we said, well, anybody over the age of 65 is at risk of heart disease, and so you should all be on aspirin. Well, that's not true. So we know that aspirin does slightly decrease the risk in that population of heart attack and stroke, but unfortunately, it also increases the risk of bleeding. So bottom line is, if you do not have vascular disease, you probably want to check with your care provider before you just start taking over-the-counter aspirin. Exercise. I won't spend a lot of time on this. Exercise is great. Exercise does a lot of good things. So it decreases cholesterol level, it decreases blood pressure, it gives you more energy, which is counterintuitive, right? You would think that if I'm exercising regularly, I'm not going to have as much energy because I'm spending that energy on the exercise. Well, that's not what really happens in practice. The first thing that I ask people when they come in and their main symptom is, I don't have as much energy as I had 5 years ago, I ask them, are you doing as much activity as you were 5 years ago? The benefits of regular exercise are numerous. The good thing about exercise is it doesn't have to be doing wind sprints. It doesn't have to be running 10 miles. A brisk walk is great exercise for the heart. A stationary bike is great exercise for the heart. Swimming is wonderful exercise for the heart. So it can be a lot of different things, and it really doesn't have to be that strenuous. The duration of exercise is more important than the intensity. So the ideal thing is to be getting 30 or 40 minutes in a day, at least 5 days a week. Cardiac rehab, which is one way to exercise, it is an answer for a lot of people. Cardiac rehab can be covered with Medicare and many private insurance companies for a whole host of reasons, and I've listed some of those here. Again, not something you can refer yourself to. So if you think you may be eligible, or if you just want to give it a try, ask your cardiologist or primary care provider whether you'd be eligible for cardiac rehab. Even if you're not eligible for insurance or Medicare to cover it, cardiac rehab for many people is quite inexpensive. And we have a great program here at LMH. We have a great program. we have for a long time. This is almost my last slide. I want to mention just briefly about atrial fibrillation, even though the focus I really wanted to bring to you this afternoon was on things that you could do to prevent developing heart disease. Atrial fibrillation is so common in this age group, I want to at least give it a mention. So this is another one of those cardiac things that as we get older just becomes more and more and more frequent. Very uncommon under the age of 50, after the age of 60 becomes more and more common, and after the age of 80 just skyrockets. So very common in the elderly, and the most important thing to remember about atrial fibrillation is how much it increases the risk of stroke. So some neurologists think that half of all strokes in this country come from atrial fibrillation. I think that may be somewhat of an overestimate, but it's a large number of strokes. And we know now that those can largely be prevented by appropriate anticoagulation. And we know that aspirin is not appropriate anticoagulation in most cases for AFib. It's just not strong enough. So we have a lot of blood thinners available now. It used to be warfarin and Coumadin was the only one we had. Effective, but very difficult to use. You have to get your blood drawn frequently and all that. We now have these NOAC, NOAC, novel oral anticoagulants. Sometimes they're called DOACs, DOAC, for direct oral anticoagulants, blood thinners. So these are all the ones you see advertised all the time. So Eliquis, Xarelto, Pradaxa, there's a new one called Saveza. They all work in a very similar fashion. The good thing about them is that they are safer than warfarin. They're more effective at reducing strokes than warfarin, and they're a whole lot easier to use logistically because you don't need regular blood draws, and they're not affected as much by diet and other medications, but they can be very expensive because none of these are generically available yet. Your doctor or pharmacy may be able to help you get these at a reduced price or even free. Those programs are out there. They are expensive, but they work very well, and they're safer than warfarin. So take care of your heart, and it'll take care of you. You know, the heart is a pretty important organ, right? I mean, there are a lot of important organs in our body, but I would put, I'd probably put the brain number one, but I'd probably put the heart number two. And if your heart is working well, you're going to feel a lot better than if it's not. So we have lots of great treatments for people with heart disease, but the best treatment is not to get heart disease. So be aware of your blood pressure and treat it if you need to, and be aware of your cholesterol levels. And if you smoke, do everything you can to not smoke. Be aware of and manage cardiac symptoms, and understand that as you get older, your symptoms may not be the typical symptoms that younger people have. You know, bottom line is, you know your body better than anything else. So if there's something new going on and it doesn't seem right, at the very minimum, it warrants a phone call to your doctor to say, should I worry about this? And they may not be able to answer that with a phone call. They may say, yeah, you need to go to the emergency room and we need to get that checked out, or you need to come in here and see me and we need to get that checked out. But if it doesn't seem right, discuss it. All right, I was told when I was at Graceland University and I took speech class that whenever you gave a talk, leave people laughing. Well, I'm not very good with telling jokes. I don't know if I'm going to leave you laughing, but I think I will leave at least some of you smiling when I put up my last slide here. So a picture of Sunday's Journal World paper. And I don't know about the rest of you, but and maybe I shouldn't admit this because it probably says something to my psyche, but I got a lot of pleasure from this game. I mean, it was never, for those of you who were either lucky enough to see it in person or see it on TV, it was never close, right? But it was very satisfying. And so I'll leave you with that photo. And I'm happy to take questions. I don't know if we have questions.
We do.
On chat or how you want to do that.
Yeah, I'll ask you the questions that people have written in the chat. That's almost as if you knew I was going to bring up Duke, just to prove your allegiance to KU.
Right.
You had that.
Yeah, I get the Duke thing a lot. I do.
Okay, well, we do have questions, so I'm just going to have at it here. Oh, my screen just changed. So you did address the question of preventative aspirin, but early on in the talk, you mentioned taking aspirin during a heart attack can be effective. Is that something I mean, if say I think I'm having a heart attack, chest pain, is that something I should do on my own? And if so, at what dosage?
Yeah, that's a very good question. And the answer is yes. If you think you're having a heart attack, take aspirin. Take 325 milligrams of aspirin, which is a regular aspirin, or 4 baby aspirin. And the most effective way of getting that in your system is to chew it. So it tastes nasty, right? I mean, aspirin doesn't taste very good, but chew it and swallow it with a little bit of water. And yes, I would absolutely recommend that. Aspirin is one of the most effective treatments that we have for people with acute heart disease, heart attacks, or unstable angina. Where we worry about its use is in the long term, but in the short term, it's quite safe, and yes, I would recommend it.
Okay, next question is, some blood pressure medications indicate no alcohol while taking the med. What is the danger if one has 1 glass of wine or bottle of beer with dinner 3 to 5 days a week? I bet you get this one a lot.
I do, and I do get that one a lot. And if that's truly the limit of your alcohol intake, there's very little danger with that, unless you have liver disease, or unless you've had a problem with alcohol before. You know, there are some people that just should be completely avoiding alcohol, and those are primarily people with liver disease or people that have had trouble with overusing alcohol in the past. But if you don't have those things, yes, it is okay to have 1 glass of beer or wine a few times a week. Frankly, it's okay to have 1 glass of beer or wine a day. Now, if you go over that, then you start running increased risk of a lot of things, including raising blood pressure. And that's where you see the warnings for patients with high blood pressure with alcohol. But 1 a day is okay. For the vast majority of people, that's okay.
Okay. If one has blood pressure issues, and I'm assuming she means just blood pressure issues, should they be seeing their primary care physician or a cardiologist?
Probably a primary care physician. You know, primary care physicians, particularly the ones we have here in town. I mean, I think Lawrence is blessed by some of the best primary care physicians around, but they do this all the time. I mean, they take care of more hypertension patients than I do. Where I get involved is when people have hypertension and something else. So they have hypertension and AFib, or they have hypertension and heart failure, hypertension and coronary artery disease. But if it's just hypertension, the vast majority of people are going to be managed very well by their primary care physician. There are occasional people that are more complex, more resistant to therapy and whatnot, that maybe will be referred to a cardiologist for that.
Okay. Is edema a serious symptom when it comes to
edema is swelling, and most probably that refers to swelling in the feet or ankles or lower leg. That's the most common place to get swelling or edema. The answer to that is it depends on what it's coming from. So lots of people get edema as they get older because of venous insufficiency. The veins have valves, and those valves over time can start to leak and break down. And then you get edema or swelling. That is not dangerous, generally speaking. Edema due to heart failure, though, can be a marker that the heart failure is not being adequately controlled. So the answer to that is most edema is not dangerous, but if you have new onset of edema, you've not had it before, then it bears looking into and discussing it at least with your primary care provider, who may refer you to a cardiologist for some additional testing.
Okay. And what does an ECG tell the doctor?
So
is that what you use to diagnose a heart attack, by the way?
Yeah, one of the things. So ECG stands for electrocardiogram. So that's the test when we put all those little sticky patches on you and run the tracing that looks like, you know, a whole bunch of wavy lines on a page. So EKG or ECG, they're the same thing. It's good for several things. It is good for diagnosing a heart attack, not all kinds of heart attacks, but the most serious kinds of heart attacks. It is good for diagnosing that. It is also good for diagnosing arrhythmias. We talked about atrial fibrillation. That's one kind of arrhythmia. It's very good for diagnosing that. It is not good for diagnosing heart failure, though. It's not good for finding some things, or fluid buildup around the heart or something. So an ECG is good for some things, is not good for other things. It is good, though, for finding the most serious kinds of heart attack.
Okay. And how do you determine if a slightly elevated cholesterol is leading to cardiovascular problems? Coronary artery CAT scan, carotid artery ultrasound, or something else?
Yeah, that's a great question too. And a coronary artery calcium scan is a very good screening test for looking for coronary artery disease. So that's available through lots of places. It's available here at LMH. I think Allison might be able to correct me, or I think it's available for about $100, something like that. So, you know, $100 isn't dirt cheap, but it's not super expensive. Most insurance plans will not cover screening tests. Some insurance plans will, and they would probably cover that. But a coronary artery calcium scan is a very good way of telling whether you have the beginning of atherosclerotic buildup in the coronary arteries. So if you have borderline cholesterol or mildly elevated cholesterol, and you're wondering, gee, is it worth me starting a statin? I'd really rather not take a pill if I don't have to. That's a good test for that.
Yeah, and I had one of those, just by the way, and it was less than 100. I'm thinking, don't quote me, but I'm thinking it was around 60 or 70, Allison. I'm not sure, but I did one of those, and it's painless.
It's painless. You don't even need an IV for it.
Yeah.
It's quick. And in terms of screening tests for, you know, we used to do stress tests. You know, you'd come in and you'd have a stress test. You'd get on a treadmill and you'd walk or run, and we do an EKG and all that. Coronary artery calcium scan has largely supplanted routine stress testing for that purpose because it's more accurate. It's safer, although stress test is not particularly dangerous, but it's easier and it's cheaper.
Allison, did you have something to add?
I was just going to try and get that information and then send it back. But
okay. And we can always put that in an email. I want to kind of wrap this up. So I think we answered your question, Joyce, with the last one. Oh, is it valuable to have periodic ECGs?
So again, it depends. It's not really very useful to do periodic EKGs if you have no cardiac history and no cardiac symptoms. Now, again, if you have atrial fibrillation or history of ischemic heart disease, bypass, or something like that, yes, we generally do one every year in those cases, and sometimes even more often than that. But you know, if you're a healthy 77-year-old with no history of heart problem and no cardiac symptoms, no, it's not particularly helpful to have one of those done on any kind of regular basis. You know, maybe every 5 years, but certainly not every year. Wouldn't be necessary.
Okay, and do you have any thoughts on a new device named Cardia Mobile, Cardia with a K, Mobile?
So
came on the market
is a device where you can record an EKG basically on your phone or on your laptop. Yes, so it works. It's not cheap. And it's generally not covered by insurance, but they do work, and they can help in some cases. For, you know, I've recommended that in some cases in patients who have periodic atrial fibrillation, for example, or other kinds of arrhythmias. You know, the other thing that's pretty good is the Apple Watch, which, you know, I wasn't at all convinced that you know, I have one. I don't have a new enough one to do the fancy stuff, but the new ones that can do the fancy stuff, they are pretty good. And I was very skeptical, but they are pretty good about finding arrhythmias like atrial fibrillation. I don't know that it's worth everybody going out and spending $600 for an Apple Watch just to look for atrial fib. But if you have a history of atrial fib and and you're wondering if it's come back or not, maybe.
Okay, I'm going to ask this question. What can I do to test my overall heart risk factors, such as coronary blockage? And I don't know if we just touched on that. She's asking me to ask this again. I have good blood pressure, cholesterol, heart rate, but can I have a test to determine if I'm at risk of heart attack or stroke, similar to the bone density test for osteoporosis?
Yeah, if you're looking for that, so I thought for initial that maybe they were asking about, a risk factor calculator, and there are a lot of those out there. If you just Google cardiac risk factor, you'll come to the American Heart Association site where you can plug in your age, whether there's a family history, what your average blood pressure is, your cholesterol. You need that data to do that, and it'll give you what your 5 and 10 year risk of a heart attack or other serious heart disease is. And we use that in the office all the time when we're making decisions on treatment. But I think what the question is more referring to physical testing, and that, again, that coronary artery calcium scan that we discussed a few minutes ago would be the best test for that. So it's better than a treadmill, it's better than a carotid sonogram to determine, the question with those kinds of things is what are you going to do with the information? But if your question is, I want to know if I'm at 2% risk or 15% risk over the next 5 years of having a heart attack, because that's going to make me decide whether I want to take a statin or not. A coronary calcium scan will go a long way to answering that question.
Okay. Yeah, apparently she's getting a lot of advertising about heart factor risk taking. She says they're between $150 and $200 not covered by insurance from private companies. So I think that's the context.
Yeah, there are a lot of screening tests out there, and I would warn people that a lot of them are just not very good quality. The kind that you can pay and then go to a parking lot somewhere, and they say they're going to scan your carotid artery and your abdominal aorta and check for AFib and check. I've seen those occasionally pick up things that are important, but I much more commonly see those pick up things that they're just red flags. And then people spend thousands of dollars and months of time working up stuff that was never there in the first place. So I would really warn people against most of those.
Okay. And then finally, because it's 5:02 and I want to honor everybody's time, especially yours, doctor, how important is family history?
Relatively important. So not as important as smoking, not as important as your cholesterol number, not as important as your blood pressure, and not as important as whether you have diabetes or not. But it's probably number 5 on those lists, of important things. So it is important in terms of prediction, but it's not anything you can do anything about. So, it heightens, I guess, your awareness of the possibility of having heart disease, but it's not a modifiable risk factor, obviously.
Okay. And I think that is it for the questions. And this is the point in time where we ask everybody to unmute yourself so we can give the doctor a round of applause for what was really a stellar presentation. And you just put that together. I just want, very good. Very good. Yeah, excellent. I hope I got to all the questions, everybody. Allison put a link to the tobacco treatment specialists in the chat. And I think, did I get them all, Kathleen?
Yeah.
I believe I did. Okay.
Yeah, I think you got
Well,
them
we
all.
can't thank you enough.
Excellent.
Dr. Zabel, good information. I'm sure we're all going to have a heart healthy holiday and with that one drink a day. But we really do appreciate it. Thanks so much.
I'm impressed and surprised actually that so many people are on, when it's 65 degrees outside, but you're all in here on your computers watching me. I'm impressed by that.
Well, good. And they ask smart questions too. They really do.
really
So we'll
great.
do another one. We'll do another one next month. We'll let you know what that is as soon as we can. Bingo is on Thursday, and that will sort of do it for our boot camp until the new year, but we will see you then. And in the meantime, have a great holiday, everybody, and hang on to your hats tomorrow during the wind.
Yeah.
See you later.
Thank
Thank
you.
you.